We'll start the bariatric surgery session. And now it's my pleasure to present Professor Haytham Al-Maleh, Professor of General and Bariatric Surgery at Ain Shams University. He will give us an interesting talk about GERD and bariatric surgery.
Thank you, Dr. Mohi. Thank you, Dr. Osama and Dr. Mahmoud. Gastroesophageal reflux disease is really an intimidating subject. It's defined as symptoms or complications occurring as a result of reflux of gastric content into the esophagus or beyond that. The classical symptoms of GERD include heartburn, regurgitation, and retrosternal pain. Other symptoms include bloating, bleaching, dysphagia, nausea, vomiting, epigastric pain, and rarely other symptoms. Long-term GERD may lead to erosive esophagitis or Barrett's metaplasia and may be cancer. How does GERD occur in obese patients? We know that physiologically there are some mechanisms that act as an anti-reflux barriers. These are the presence of lower esophageal sphincter, the diaphragmatic crura, the intra-abdominal length of esophagus, the high intra-abdominal pressure, the acute angle of His, and the gastric sling fibers, and the phrenoesophageal ligament. In obese patients, gastroesophageal reflux disease can be due to one of the following multifactorial mechanisms. The first is transient relaxations of the lower esophageal sphincters in absence of swallow. The second is decreased lower esophageal sphincter pressure. Any disturbance in normal anatomy as in hiatus hernia, gastric distension due to large stomach volume, increased intra-abdominal pressure due to mesenteric fat, and hyposalivation, which decreases esophageal clearance. In obese patients, the large gastric capacity leads to increased intragastric pressure. All of this, together with the negative intrathoracic pressure, will lead to GERD. A study reported that in obese patients, for every 5 points of BMI increase, the D Mastery score of reflux increases by 3 points. Another study had demarcated that the visceral obesity or the visceral fat is the main factor that's linked to the increase of incidence of Barrett's esophagitis and esophageal adenocarcinoma. What's the relation of bariatric surgery to GERD? Bariatric surgery may lead to decrease in GERD via the following mechanisms. The first is reduction or repair of hiatal hernia during the bariatric surgery. Most of the bariatric surgeons, when they find a hiatal hernia, they fix the crura and fix the hernia. But routine dissection of the hiatus in all patients, whether they have or they have not a hiatus hernia, may lead to disruption of the mechanism that which was predisposed to the formation of GERD after surgery. The second mechanism is the reduction in acid production, either due to resection of the part of the stomach, as in sleeve gastrectomy, or exclusion of the part of the stomach in other bypass operations. The third mechanism is reduction in acid exposure. In bypass operations, the exclusion of stomach remnant in the bypass surgeries lead to decreased exposure of the esophagus and the gastroesophageal junction to acidic content reflux. The fourth, presence of a gastrojejunostomy in bypass operations will lead to a creation of a low pressure system. This low pressure system will decrease the intragastric or intra-pouch pressure, leading to decrease of GERD. The fifth mechanism is the downward traction exerted by the enteric bypass in bypass operation. This downward traction leads to lengthening of the intra-abdominal length of esophagus and decrease of GERD. There are other mechanisms caused by bariatric surgery that increase GERD. Different bariatric operations have different effects on GERDs, but in theory, all bariatric operations can cause GERD. But the balance between the protective anti-reflux mechanisms and the reflux-causing mechanisms is different between operations. So the net result is different in different operations. The potential refluxogenic mechanisms of bariatric surgery involve division of the phrenoesophageal ligament, blunting of the angle of His, division of the sling fibers, restrictive pouches as in a sleeve, which leads into increased intragastric pressure, delayed gastric emptying due to the cut of the muscle fibers of the stomach, and impaired esophageal peristalsis, and in some cases, bile reflux. This is a diagram of which operation have a more refluxogenic effect according to its anatomical characteristics. The take-home message is the problem of GERD may be present after any type of bariatric operation. The best available evidence about each operation, first after sleeve gastrectomy. There is a very large body of literature now supporting the fact of development of new gastroesophageal reflux disease and Barrett's esophagus after sleeve gastrectomy. We have two types of patients. Those with prior GERD may have worsening GERD. Those without prior GERD may have de novo GERD. First, there are mechanical factors that may lead to GERD after sleeve gastrectomy, as undiagnosed esophageal motility disorders and some technical factors as large fundic pouch, intrathoracic sleeve migration, presence of tight sleeve or stricture or twist of the sleeve, and other disorders. This is a study done in 2018, in which the authors has performed manometric and pH analysis of all patients before and after sleeve gastrectomy. After 1 year, they have found that 66% of patients are free of GERD. 34% of the patients have GERD after surgery. Of these patients who had GERD before surgery, about 37% of them, the symptoms have become worse. The remaining 63% of previous GERD did not have any improvement after surgery. And of the patients who have no GERD, they have found 56% de novo GERD, new GERD. This is another study. I've performed a prospective analysis of 35 patients with endoscopy, pH and manometric study. After 1 year, they have found a significant increase in reflux episodes and in acid exposure times, and decrease in the lower esophageal sphincter pressure. This is another study which have done endoscopy and pathology of the distal esophagus and stomach before and late after sleeve gastrectomy. They reported that they have de novo GERD in 60% of patients, hiatal hernia in about 40% of patients, and Barrett's esophagus in 4% of patients. Only 13% of patients who had previous GERD had resolution of GERD. This is another long-term follow-up study, which is done in Austria for about 100 patients, which have been followed by endoscopy, manometry, and pH study. They noted the development of Barrett's esophagus in 14% of patients, de novo Barrett's esophagus. About a third of their patients needed conversion for gastroesophageal reflux disease. Due to these factors, the IFSOS and the SMBS have recommended that after sleeve gastrectomy, you should do an upper GI endoscopy after 1 year, and then every 5 years to every patient who undergo sleeve gastrectomy. So, the take-home message, that the evidence suggests that there is increased incidence of GERD and its complications after sleeve gastrectomy. The second operation is the one anastomosed gastric bypass. The one anastomosed gastric bypass carries mainly the danger of bile reflux more than acid-related gastroesophageal reflux. The literature evidence available about one anastomosed gastric bypass is not as abundant as a sleeve gastrectomy due to the relative recent acceptance of the operation worldwide. But there is still an evidence. The factors that may contribute to reflux after one anastomosed gastric bypass may be esophageal, maybe gastric as leaving a large part of the fundus, or intrathoracic migration of the pouch, tight pouch stricture or twist in the pouch, or marginal ulcer, or presence of gastrogastric fistula, or any cause of distal obstruction. This is a study done in Italy by Professor Musella, in which he studied patients with either one anastomosed gastric bypass or a sleeve gastrectomy. And he had found there is better result of patients with GERD in one anastomosed gastric bypass as compared to sleeve. But there is an insignificant increase in non-acid reflux, which is the bile reflux, about 50% increase after Roux-en-Y gastric bypass, after one anastomosed gastric bypass. This is another study which analyzed the intraluminal pressure and pH parameters in 11 patients after one anastomosed gastric bypass. They have found that the number of reflux episodes decreased as acidic reflux episodes, and the number of non-acidic reflux episodes has increased. They have also found that the Mystery score has increased after one anastomosed gastric bypass, denoting that the operation has some refluxogenic nature. They also noted 28% of the patients have de novo reflux. This is a study which is studied about 90 patients with one anastomosed gastric bypass. They have found that 61% of the patients have post-operative GERD, and interesting-wise, 14% of the patients who undergo one anastomosed gastric bypass needed conversion to Roux-en-Y gastric bypass. This is another study which investigated patients with symptomatic GERD after one anastomosed gastric bypass. They have found abnormal acidic reflux in 30% of patients, bile reflux in 27% of patients, and mixed reflux in 11% of patients. And after 1 year, they have 50% of patients have esophagitis. 40% of them are new esophagitis. This is another study which concentrated on bile reflux. They have found that bile reflux in the gastric pouch is present in about 30% of patients after one anastomosed gastric bypass, with 3% of patients having bile reflux esophagitis. So about 22% of the patients have GERD, and 14% have new onset of esophagitis. This had led to the EFSU also recommending a timely post-operative endoscopy follow-up for all patients undergoing one anastomosis gastric bypass. The Roux-en-Y gastric bypass. We have all been taught that the Roux-en-Y gastric bypass is the gold standard for treatment of GERD after bariatric surgery or the primary management of patients with GERD. But it's not that simple. The Roux-en-Y gastric bypass is not free of GERD. It has some advantages. There is a low intra-pouch pressure. There is a low acid exposure due to the small pouch and exclusion of the stomach. There is a downward pull, and the Roux-en-Y configuration prevent bile reflux. But there may be, due to anatomical factors, some reflux after Roux-en-Y gastric bypass. This may be due to a large fundic portion of the pouch, or also intrathoracic migration, or inappropriately large pouch, or candy cane syndrome, or presence of gastrogastric fistula, or marginal ulcer, or pouch stasis syndrome, or any distal obstruction. This is a study which studied patients with reflux symptoms after Roux-en-Y gastric bypass. And when assessing these patients with endoscopy and GI physiology, manometry, and pH, they noted that 53% of these patients who had reflux after Roux-en-Y gastric bypass had hiatal hernias. 23% of these have grade B esophagitis, and about 38% of them have some sort of esophageal dysmotility. Another study has studied the patients 5 years after laparoscopic Roux-en-Y gastric bypass. They divided the patient into two groups, those with GERD and those without GERD. The incidence of acid reflux and weak acid reflux and combined acid reflux was studied. They found that in patients without GERD, there is 14 patients, so 30% of patients have silent grade A esophagitis. And the patients with GERD, 70% of them have esophagitis. There is a decrease in the acid reflux parameters, but there is an increase in weak acid reflux parameters. So, the Roux-en-Y gastric bypass may have, in some patients, a problem of gastroesophageal reflux disease, although less than sleeve gastrectomy and one anastomosis gastric bypass. So we know that reflux after bariatric surgery is a problem, exists after all operation, and it's mostly in the sleeve, leastly in the Roux-en-Y gastric bypass. How to approach those patients with reflux after a bariatric operation? The first is careful history taking about the surgical history, the need of proton pump inhibitors, timing of reflux, meal injection, and any other symptoms. After that, we proceed for investigation. The first investigation is upper GI endoscopy. The second is barium or gastrografin studies. The third, we can have the benefit of CT reconstruction with volumetry. The third, we do a pH study or impedance study or other GIT physiological study. And in some cases, we may need a gastric emptying study, or in patients we do not have any clue, we may need a diagnostic laparoscopy. So how to treat them? First, patients with known anatomical variations due to the operation, this should be corrected. Like patients with hiatal hernia or intrathoracic sleeve migrated should be surgically corrected. Patients with candy cane should be excised. The gastrogastric fistula should be excised. Twisted and strictures of sleeves or gastric pouch should be managed. Marginal ulcers should be treated. Other causes of distal obstruction should be treated. Then, in the absence of all of these factors, the first line of treatment is try to change the patient's lifestyle, add medical treatment. And the patient should know that these changes and these medical treatments can be lifelong. If this is failed, there are some endoscopic therapies. These are the endoscopic therapies that can be used in non-bariatric surgery patients. The injective therapies are not suitable for patients with bariatric surgery. The first of the methods that can be used in bariatric surgery patients is the radiofrequency ablation of certain points in the gastroesophageal junction with the Sterta procedure. This will create a zone of increased lower esophageal sphincter peristalsis and increased lower esophageal sphincter pressure. It has been studied in a few number of patients. The GERD related health quality of life did not decrease significantly with the procedure, but the patient decreased PPI use in 20% of patients. This is an animation of the procedure in which a catheter is placed in the gastroesophageal junction, and through anchors they do a radiofrequency ablation of multiple points in the mucosa. The second is anti-reflux mucosectomy. The anti-reflux mucosectomy is a type of endoscopic mucosal resection of the gastric cardia using the EMR technique. The exact mechanism is creating an ulcers in the lower esophageal junction in a certain manner that will lead to creation of something like a new valve. This is also an animation of the procedure. It's done, they inject saline, create a bolus, snare the mucosa, create an ulcer, and they do this in multiple places to create a circumferential non-complete zone of high pressure and like wrap-like effect. The third endoscopic procedure is the transoral incisionless fundoplication. It's called the esophagus. In this procedure, we use a specific device which creates a wrap through an internal wrap using the upper GI endoscope in a semi-automatic manner. All of these interventions have only few anecdotes published on them. The surgical management. The first option is to convert the patients to Roux-en-Y gastric bypass. This is the classic option. After a sleeve gastrectomy and one anastomosis gastric bypass. It's safe, it's successful, it's have a very high success rate. The second option is concurrent surgery. When doing a bariatric surgery, is to preserve or repair the crura, preserve the angle of Hess, dissect the esophagus to obtain a proper length, and doing the procedure, which are either sleeve gastrectomy or gastric bypass. Some studies have added to this a concurrent fundoplication. The first study have done a 180 degrees cardioplication to the sleeve gastrectomy or gastric bypass or transit bipartition patients. They studied 88 patients at about 2 years. They say that they have 61% of resolution of GERD symptoms, 63% decrease in proton pump inhibitor use. This is compared to 6 and 12% in patients who did not undergo this procedure. This is a picture of a completed 180 degrees wrap after sleeve gastrectomy. The second is doing a complete Nissen fundoplication after a sleeve gastrectomy. And this is a technique called Nissen sleeve, which was populated by Professor David Luca in France. He, in his published studies, has described a complication rate of about 9%, including gastric perforation and gastric stenosis, but about 90% remission of the symptoms of GERD. 50% of his initial sample have had weight regain, so he had to revise to address this. A systematic review was done to assess 4 studies who have done sleeve gastrectomy with Nissen fundoplication. They had a rate of GERD remission of about 90%, excess weight loss of about 50-60%, post-operative complication rates of 6%. Although most of the surgical society thinks that this is a high-risk procedure. The other option is the magnetic sphincter, the sphincter augmentation surgically. One of the options to augment the sphincter is the ligamentum teres cardiopexy, which can be done by with a sleeve or gastric bypass. A study studying that have found that after 36 months, resolution of symptoms of GERD in 60 to 100% of patients. Another option is using the remnant stomach to do a fundic wrap in bypass operations as one anastomosis gastric bypass or even Roux-en-Y gastric bypass. Another option which has been reported that doing a full Belsey Mark IV fundoplication, which has been done in a few cases. The least surgical option is a new option, which is the magnetic sphincter augmentation using the Lynx ring. It is a titanium magnetic ring, which is placed laparoscopically around the gastroesophageal junction. It creates a new valve that acts as the lower esophageal sphincter valve physiologically. This is the ring. This is a model of how it's placed. This is an intraoperative picture of the Lynx ring. This is a gastrographene study showing the ring. So, to sum, if you have a patient of a sleeve gastrectomy with GERD after it, first exclude the anatomical factors. If there is no anatomical factors, try medical treatment. If the anatomical factors are corrected, you may try conversion to bypass or endoscopic procedure or links. After one anastomosis gastric bypass, you have similar options, but after a Roux-en-Y gastric bypass, the only available options are either endoscopic options or using the sphincter augmentation mechanisms. How do you follow up these patients? They should be have surveillance by upper GI endoscopy at 1 year and every 2 to 3 years for any patients undergoing sleeve gastrectomy or one smooth gastric bypass. The patient should be counseled before any bariatric operation that they may have GERD symptoms if they don't have, or the GERD symptoms may be worse if they have, and that may lead to another operation to treat that. So, the key learning points, GERD is a common. Symptoms are not enough to diagnose GERD. All bariatric procedures may cause GERD. GERD is more common after sleeve gastrectomy. Post-operative surveillance for GERD is recommended for sleeve and one smooth gastric bypass. Complete evaluation of patients with GERD should be done. The decision for the management should be MDT based. Thank you.
Thank you, Dr. Haitham Al-Maleh, for the very nice presentation. Is there any question? There is no question? Thank you, Dr. Haitham.